Today, I will be sharing with you the results of an assessment of pain associated with respiratory disease and its mitigation with Flunixin Meglumine in cattle with induced bacterial pneumonia. BRD has long been one of the most costliest and common diseases that affect all segments of the cattle industry. The most commonly isolated organism from BRD affected lung tissue is an opportunistic pathogen that's known as Mannheimia hemolytica. And pleuritic chest pain as a result of this bacterial pneumonia is commonly reported in human medicine, but published literature regarding the association of pain and respiratory disease in cattle is lacking. So the objective of this study was to assess if bacterial pneumonia does elicit a pain response in calves with experimentally induced BRD, as well as to determine the analgesic effects of Flunixin Meglumine transdermal in bacterial pneumonia. So our study timeline began with the calves arriving at the K-State stocker unit and having a 2-week acclimation period, at which point in time, all flex ear tags were placed that recorded activity and rumination from the calves. At negative 48 hours, calves were assigned to one of 3 treatment groups. Baseline outcomes were collected, and accelerometers that measure lying and standing bouts and steps were placed on their back left legs. At negative 24 hours, calves were inoculated via bronchoalveolar lavage with Mannheimia hemolytica. At 0 hours, the treatment was administered. There were 3 treatment groups. One group was inoculated with Mannheimia and received Flunixin transdermal. One group was inoculated with Mannheimia and received a placebo solution. And then we had a control group that was inoculated with saline and received the placebo solution. And then from 0 to 192 hours post-treatment, outcome variables were collected. And these included rectal temperature, infrared thermography imaging, pressure mat gate analysis, mechanical nociceptive threshold, visual analog scale scoring, clinical illness scoring, a computerized stethoscope lung score, and then blood sampling for plasma cortisol and substance P analysis. Then at 192 hours, calves were euthanized and transported to the K-State BDL, where lung lesion scoring occurred. So we saw a significant association between whisper lung scores and clinical illness scores. Calves who had an abnormal clinical illness score, a higher percentage also had an abnormal whisper lung score. We saw a significant association between the all-flex tags, SCR activity, as well as whisper lung scores. Calves with an abnormal whisper lung score were less active. And then we saw a significant association between mechanical nociception threshold and clinical illness scores. Calves with an abnormal clinical illness score were more sensitive to force, likely meaning that they were more painful when this force was applied over their 6th intercostal rib space. So what we can conclude from this is that outcome variables that can be effectively used to quantify pain from BRD may include mechanical nociception threshold, clinical illness score, whisper stethoscope lung score, and all-flex SCR activity data. And relationships between these variables and treatment outcomes warrants further investigation when quantifying pain associated with BRD. Thank you.